He'll speak to us about adverse biochemical parameters affecting the response of anti-VEGF treatment in DME. Can the coordinator please try to call up?
We called him, he's not available, sir.
A very good morning to everyone present here. My presentation is novel biochemical parameters affecting the response of anti-VEGF drug treatment in diabetic macular edema. I have no financial interests. As we all know, the current global prevalence of diabetic retinopathy is 126 million among 382 million people with diabetes. Anti-VEGF came into existence following extensive research and studies. It currently plays a pivotal role in the treatment of diabetic macular edema. However, it has been seen that 15 to 20% patients in diabetic retinopathy do not adequately or fully respond to anti-VEGF therapy and require alternate treatment strategies for their management. Several studies have shown that advanced lipooxidation end products have a role in the pathogenesis of different oxidative-based diseases, including diabetes. Amongst ALEs, 4-hydroxy-2-nonenal and N-epsilon hexanol lysine are the newest biomarkers which have gained attention. Additionally, the enzyme lactase dehydrogenase levels have been significantly associated with the progression of diabetes and also with obesity. The aim of my study was to find out if there is any association of serum levels of ALEs and LDH with non-response to anti-VEGF treatment. This was a retrospective case-control study carried out between the period of January 2020 to May 2021. Patients with both type 1 and type 2 diabetic mellitus attending our OPD were considered for this study. They had received monthly 3 anti-VEGF injection ranibizumab with or without focal grid laser treatment based on the discretion of the physician. The patients had a follow-up at 4 months. The inclusion criteria was greater than 20 years or older patients, center involving DME, in non-proliferative or early PDR cases. Baseline BCVA was between 0.1 and 0.2, and a baseline CMT of 300 micrometer or more, and well-controlled diabetes, that is serum HbA1c levels of less than 10%. The exclusion criteria was any prior vitreoretinal surgery, any prior history of anti-VEGF injections, any significant media opacity, presence of other diseases, other retinal diseases other than diabetic retinopathy, any known cardiovascular diseases, renal, liver diseases, severe anemia or thyroid disorders. The baseline BCVA and OCT was performed at the baseline and at every follow-up visit. Patients were then stratified into 2 treatment groups. They were considered as responders or non-responders. Responders were those patients who had gained more than 5 ETDRS letters or an improvement of more than 50 micrometer from the baseline CMT. Those who did not fulfill their criteria were the non-responders. All of these patients, their blood levels for LDH and ALE levels were estimated at the final follow-up visit. The plasma LDH activity was measured using enzyme kinetic assay kits and other commercial kits. The ALE levels was measured using ELISA kits. The results were 192 patients were evaluated. Amongst them, 143 were male, 49 were female. The main baseline BCVA score and the CMT scores are as follows. According to BCVA evaluation, 115 eyes were responders and 77 eyes were non-responders. As we can see here, all the patients, both responders as well as non-responders, had a significant improvement in BCVA as well as significant reduction in CMT. In all the patients, the non-responders had higher levels of LDH, higher levels of advanced lipooxidation end products, both HNE as well as H12Y levels. We tried to find a correlation between the LDH levels and BCVA and CMT. A negative correlation was seen in cases of LDH levels. However, in cases of ALE levels, a positive relation was seen in the responders and a negative correlation was seen in the non-responders. Similarly, for ALE HLY levels, a positive relation was seen in the non-responders group and a negative correlation was seen in the non-responders group. So we can see novel biomarkers like LDH and ALE levels showed statistically significant high levels in non-responders compared to responders. Earlier, it has been seen that aqueous sample biomarkers like IL-8 and MCP1 levels were found to be higher, as well as OCT imaging biomarkers like extensive external limiting membrane disruption, traction lateral membrane, drill and ellipsoid zone disruption were considered to be significant, but no known serum biomarkers have yet been detected. This technique of detecting LDH and advanced lipooxidation end products in human blood using ready-made kits is an easier alternative. We detected a statistically significant positive correlation between HLY levels with the final BCVA only in case of responders. Although not statistically significant in responders, a positive correlation was found between HNE and the final BCV and CMT levels, and between HLY with the final CMT. LDH levels, however, no such correlation significance was found. The limitations of my study were the low statistical power, its retrospective study design, and thirdly, the non-uniform use of focal grid laser could be a confounding factor. Regardless, the study provides a framework for further research. So we can conclude that the serum level determination of ALE levels like HN and HLY could help to predict responsiveness of anti-VHF injection ranibizumab in diabetic macular edema. Thank you very much.
Thank you. It was an interesting study. Could you please tell us why did you select LDH as one of the biomarkers and why the HLY and HNE? Are there any other advanced lipoxidation products also which can be tested?
No, there was no such an indication, but it has been seen that LDH levels play a role has a role in case of diabetes. Other studies have been found, but no such study has been found relating it to diabetic retinopathy. We just researched other systemic illnesses and we tried to see whether this could play a role. So LDH was not found to be significant here, only ALE levels were found to be significant.
Was the LDH level chosen because of any relation with a low-grade pancreatitis which would exist in long-standing diabetics? Was there any such consideration, in which case, of course, even amylase perhaps should have been?
Yes, sir, but we tried to exclude other systemic illnesses. It could play a role in multiple systemic illnesses, but we tried to exclude these illnesses.
And are there any other lipoxidation, products which can be estimated other than HLY and HNE?
We estimated these two circuits only.
But good, very good.